So as Lynn said, I've spent many years at 0 to 3, which is a national organization founded by pioneers in the field of infant mental health. I left there in February, but I do continue as a board member for the Ohio Association for Infant Mental Health. Lynn, you could go to the next slide if you want. And I also I am a member of the Northeast Ohio chapter of the Infant Mental Health Association, and I'm working on a local group that's trying to get a safe baby court team started here in Cleveland. So I continue to be active even though I'm no longer employed by 0 to 3. But they were kind enough to give me permission to use some of the content. So you'll see that logo throughout on the slides. And I do want to acknowledge that, we've got a governor, Governor DeWine, who really supports children's initiatives. So it's really a perfect time to be thinking about advancing infant mental health in Ohio. And I say advancing because many, many years ago when I was with the state health department at the very beginning of their early intervention system, that's when I first learned about infant mental health. And when I did learn about it, it felt like I had finally found the missing piece. The piece that connected what we do with children with what was happening in their relationships with their family and other significant people in their lives. So, I think about it as advancing, not beginning something here in the state. So what I plan to do today, and we will certainly be watching for your questions and leave time at the end for questions, but what I'm hoping to do is to do a little bit on, exactly what is infant and early childhood mental health, why it's important, and what the science is behind it. Without that grounding, some of the recommendations may not make as much sense. So we're going to cover that quickly. And then, and not too quickly though, there's a lot of it. So that's what I plan to do today. In the policy portion, I will try to include examples from other states as much as I can. So, all right, let's go to the next slide. I'll keep talking while we advance the slide. So infant mental health, or infant and early childhood mental health, is not really a term that rolls easily off anyone's tongue. And we often have some puzzled looks when we bring it up. Go ahead and go to the next slide, Lynn. There is an official definition of infant mental health, and that's what you see on the screen. It's the developing capacity of a child from birth to 5. It has to do with experiencing and regulating emotions, forming close relationships, and exploring the environment and learning within the family and cultural expectations. So that's the official definition. I think of it, and I should say, I'm not a mental health professional. So in some ways, that's made it much easier for me to try to explain all this to advocates and policymakers and program directors, because I don't have that clinical perspective. I have the practical orientation of, well, what does it mean for me? So from my perspective, I see it as just that area of development, how kids develop socially, emotionally, and relationships during the first 5 years of life. I hear all kinds of terms being used to describe this: behavioral health, pediatric mental health, relational health, social emotional development, and actually the field probably prefers the term infant, early childhood, and family mental health. But that's a lot of words. So I just will, especially in this presentation, we'll call it infant mental health for shorthand, but just keep in mind that we're talking about another area of development. All right, let's go to the next slide. So why is this area of development so important? Go ahead, next slide. Well, First, it's fairly prevalent. Studies have shown that between 10 and 14% of children under the age of 5 will actually have a mental health disorder. That means something that can be diagnosed accurately and have treatment to go along with it. So it's fairly prevalent. And for children living in families where there are additional stressors, social determinants of health, and so on, there's even a higher risk. So if a child has lost a parent, maybe to death, or maybe they're in prison for an extended period of time, parental substance abuse, which of course is a huge issue here in Ohio, parental mental illness, exposure to trauma, those children have an even higher risk. I include in this sort of background some of the early warning signs of mental health disorders. But I think when you hear on the next webinar from the frontline clinicians, they will be able to give you even more detail about how it is that we know if a child has a disorder. But what they typically see, very often a referral will come based on behavior, but there may also be inconsolable crying, children that just don't seek comfort, that are not curious, maybe withdrawn, maybe exhibit developmental delays. And for those of you who are in the early intervention world, of course, you need to sort out if that delay is coming from something rooted in the emotional health of the child and the parent, or if it's coming from something else. And then I've listed a few examples of what mental health disorders there are. Young children can suffer from depression. They can have post-traumatic stress disorder. Children can have ADHD, although it is not appropriately diagnosed in very extremely young children, but children 4 and above can have ADHD, and separation anxiety disorder is another common one that is seen. So that's sort of the prevalence and what they might look like early on. Next slide. And as I think everybody is probably familiar with the adverse childhood experiences, or ACEs studies, that have shown quite conclusively that what happens in the early years has an impact on health and well-being much later in life. And so mental health disorders in very young children and those risk factors can also increase their risk for physical and other health outcomes. And so drug use, alcoholism, depression, those are all related to children having mental health issues when they're very young. There's also an increased risk for juvenile justice and lifelong criminal justice involvement. And many of those, there's not a direct relationship between having a disorder when you're young and ending up in the juvenile justice system. It's more typical that the folks in those systems have had mental health needs that went undiagnosed or untreated. So it's really the lack of treatment that increases the risk, not the fact that a young child has a disorder. And of course, there are negative impacts on school readiness, being able to pay attention in school, or tune in enough without being worried about what's happening in the environment. Those are all ways that early mental health issues can have a negative impact on school readiness and educational attainment. And the bottom line for many programs is that it leads to much, much higher lifetime costs. And later on, I will reference a study that was done in the state of Alaska on the savings to Medicaid if the ACEs in Alaska were prevented or addressed early. And the cost savings is really quite dramatic. So I will get to that in a later slide. So let's talk for a minute about the science behind infant mental health. And it really comes from several different areas of science. So from the brain science and other research that looks at child outcomes and early development, there's clear evidence that our early experiences influence the physical structure of our brains. Our brains grow very rapidly in the first years of life, and in order to operate efficiently, the brain has to selectively prune some of those connections. So with repeated experience, connections get stronger, and without repetition, some connections are lost. So, of course, we want for young children that they have more positive experiences, like being surrounded by at least one nurturing relationship, that they have adequate nutrition and healthy environments. All of those things help support healthy development in all areas: growing, walking, talking, thinking, doing, feeling, all of those areas. At the same time, because again, the brain is wired through repeated experience, if a child's experiences are repeated negative experiences, what are generically called ACEs, those can also have long-lasting effects on the brain and child development. So for instance, children who are growing up with daily episodes of violence, or in a family completely stressed by poverty, substance abuse, and so on, the child's brain is wired very differently. The child's brain becomes wired to perceive threats, to be prepared at all times to flee or to fight or to withdraw. And what I think is one of the most amazing uh, uh, findings from brain research is that that adversity can be buffered through a positive relationship between a child and an adult. And that's why those early connections, what we used to call bonding, are so incredibly important. Not only are they emotionally supportive, but they literally can help change the wiring of the brain and reduce the stress hormones for a child in that situation. From the medical research, we know that infants and young children do have mental health disorders. There are actually 42 disorders that are outlined in the manual that, for shorthand, we call DC 0 to 5. I will tell you what that all means in a minute on another slide. And we know that trained clinicians can accurately diagnose conditions before the rest of a child's development is compromised. Also from the medical research, we know that those untreated disorders do affect growth and development, and that means that early adversity, those ACEs, can literally take root in a child and accumulate, which is why on that earlier slide where we saw the impacts over time, those effects build up. And we know that while recovery is possible later on, it is much harder and much more expensive if we wait. From the science of child development and attachment, there used to be this saying, there is no such thing as a baby, only a baby and an other. And that means that relationships, connections between babies and their caregivers are literally the catalyst and the context for all early learning. everything that a baby learns and a young child learns is mediated through relationships. And I know for any of you who are part of early education programs, you know that that means the teachers are important, the parents are important, and the other children are important. In the resource list at the end of the slides, I did include a link to the Harvard Center on the Developing Child, which has really wonderful resources describing serve and return relationships and how that looks in very young children. So the bottom line is that infant mental health is just as important as physical health in determining a child's future. That early relationships are absolutely essential to the biological and emotional development in children. And that's why we have a lot of work to do to make improvements across a continuum of mental health services and supports. So this is the continuum I'm talking about on this next screen. Infant mental health spans promotion, prevention, assessment and diagnosis, and treatment. And this continuum does not exist as a separate system. These activities are integrated across any provider, any system that serves children and families. So promotion are all those activities that raise awareness and encourage positive social and emotional development. That could be routinely talking about social and emotional milestones on a home visit. It could mean integrating infant mental health into training for childcare. It could mean disseminating information about the early foundations of school readiness to parents. It could be talking to parents of children with disabilities about how they can work on curiosity or regulation. So promotion are really those awareness-raising activities. In the prevention realm, we're talking about identifying risk factors, mitigating adversity, and intervening in child and caregiver relationships that may threaten healthy development. So it might mean screening for exposure to trauma, might mean screening for parental depression. It definitely includes early childhood mental health consultation in childcare, early care and education, home visiting. It might include offering parenting groups that can help strengthen parents' confidence and skills. So that's all prevention. In assessment and diagnosis, the cover of the book that you see there is DC 0 to 5. And the reason we shorthand it is that the full title is The Diagnostic Classification of Mental Health and Developmental Disorders of Infancy and Early Childhood. Hence the shorthand. It is a manual that is intended to complement the Diagnostic and Statistical Manual, which is the manual that is used in mental health to diagnose older child, adolescent, and adult mental health disorders. So it is the one that is appropriate, though, for children from birth to 5, written and intended specifically for that age range. That's what we mean by developmentally appropriate assessment. It's very difficult to accurately diagnose without pathologizing normal or typical development, without having something that's specifically developed for young children. So we're very keen on getting that into practice. And I know, I don't believe it's in policy in Ohio, but it's definitely used in practice by many mental health providers in Ohio. And then the most intense part of this continuum is treatment. Treatment has to be based on accurate diagnosis. And I always have to note, we do not diagnose children, we diagnose conditions. And the reason we do that is to make sure that they can get into effective treatment as soon as possible. And again, there are evidence-based treatments, child-parent psychotherapy, parent-child interaction therapy, attachment by biobehavioral catch-up that are designed and tested and used specifically for very young children for specific mental health disorders. So, all right, well, that was a very quick overview of the science behind infant mental health, the continuum. So let's move to the concrete ways that we might be able to advance infant mental health. All right, let's go to the next slide. And I want to say that even though, I've got a lot in my head, these recommendations did not totally come from my head. These came from the experience of many states who have been working on some of these. I can't say that any state has everything in place that needs to happen. But when I was at 0 to 3, we had a 20-state project where each state had a cross-agency team that came up with infant mental health strategies, and a lot of the learnings that I'll share come from that group, but other states as well. So, oops, looks like they all got number 1. Well, it just shows they're all priority. These 4 areas of action. I'll go over each of the areas and offer some suggestions. Let me just say them out loud for people who might hear the recording and not see the slides. The first area is grow, train, and support infant mental health workforce. The second area is build systems that support integration. The third area is secure and sustain financing for infant mental health services. And the fourth area is cultivating leadership inside and outside state government. So let's move to that first area. So workforce development, and I do get the question pretty often, where do we start? What's the right place to start? And I always say start anywhere. It's probably why those 4 areas all got labeled number 1. But many states have started with growing their workforce. And Ohio is very much like other states in that we need more infant and early childhood providers, especially providers who are on that more intense part of the continuum where they're trained to provide the assessment, diagnosis, and treatment of young children. We also need to keep more people in the system, though. We need to have providers that are getting ongoing training, that have a network, and that get reflective supervision, which is the piece that helps folks doing this very difficult work understand what they're bringing to the work and what they're taking out of it at the end of the day. So some of the recommendations in this area, first would be to conduct a workforce assessment. I don't think that that's been done. Invest in Children here in Cuyahoga County is doing that, a workforce study right now. So it'll be very interesting to see what they find, and maybe other counties could replicate that. North Carolina and South Carolina both surveyed training needs, and they are 2 states that have really tried to use their quality improvement system in childcare and integrate infant mental health into those systems as well. And Alabama recently conducted a survey of all their behavioral health providers, both the adult providers and the early childhood providers, to see where they needed to fill gaps in those skills. So that's one area. Second area is to implement competency standards and endorsement for mental health providers. And this is an area that many states have taken up. Um, about 30 states have now purchased the competency and endorsement system developed by the Alliance for the Advancement of Infant Mental Health. And a few states, California, New Hampshire, I want to say Illinois, but I don't know where they are with developing their system, but a few states have developed their own competency and endorsement systems. So there are somewhere around 35 of the 50 states that now have a way to verify that individuals really across the continuum have reached a level of um, uh, knowledge and skill, mostly knowledge, to be able to provide infant mental health services and supports. And so, for individuals, it certainly enhances their credibility and confidence. But I think from the employer's point of view, having an endorsement system for infant mental health verifies that the people you're hiring have attained this level of functioning and understand what they're doing, which is a big deal when you're hiring staff. And in fact, Alabama and Michigan have worked with their Medicaid departments and now require behavioral health providers that serve children birth to 5 to have an infant mental health endorsement in order to bill. So it's becoming more of a standard of practice beyond just the training and supports that one gets from being endorsed. So that is a big area, and the Ohio Association has really been working hard to get this to happen in Ohio. A third workforce area is to embed infant mental health education into child care licensing requirements. And I think Ohio really has done a good job at this. It's been part of the special needs child care. There's been training, but there's always room for improvement. So I think that should stay on the list of things to be done. And then a fourth area is to create graduate coursework if none exists. And Ohio does not have an infant mental health graduate program. And we know that there's very little content on infant mental health in graduate schools and social work programs and so on. The state of Oklahoma actually created a graduate program called the Institute for Building Early Relationships, or IBEAR, just so that they could satisfy the market for that level of coursework. And they also, in conjunction with that, created continuing medical education that they provide by distance learning. So there's a lot to be done in that workforce area. So let's move to the next area of opportunity. So in the area of financing, there is always a lot to be done. And so many states have started with just mandating that Medicaid, and I talk a lot about Medicaid because it's often the thing that drives the rest of the financing system. And about half of the children are covered by Medicaid. So that's why I focus on that. So mandating that Medicaid providers follow Bright Futures guidelines. Ohio already does that. Our health check program already follows Bright Futures screening, but we don't know if providers are referring for further evaluation and treatment. So that's kind of a big unknown. The second area of action would be to require the use of a more age-appropriate diagnostic system. And so I already mentioned DC 0 to 5. This is the one that that really is the standard of care when it comes to mental health and developmental disabilities. Would love to see that happen in Ohio. DC 0 to 5 also recommends multiple sessions for assessing infants and families. Um, you can just imagine that if a baby is sleeping during an appointment, you're not going to be able to evaluate a relationship. And young children, need to be engaged in play and build enough trust with the assessor. So those multiple sessions, that's the recommendation, but there's got to be a way to finance that. So some states have passed what they call extended diagnosis rules, where a child can be assessed over 3 sessions and the providers receive a higher reimbursement rate. Other states have passed rules allowing multiple visits before a diagnosis is made. So in North Carolina, a family can actually see a mental health provider for up to 16 sessions and receive lots of information, lots of support, and lots of guidance before a diagnosis is made. So those things just allow a more appropriate approach to children and families. Advocating for greater access to select billing codes. It just means we need to be able to bill for infant mental health treatment. This one is very, I want to say, labor intensive and time consuming, because what that means is that, the current Medicaid and managed care plans would have to be reviewed, provider manuals would have to be reviewed, um, uh, codes would have to be reviewed, data systems might have to be changed. That doesn't mean it shouldn't be done, but it is something that is a little bit more time intensive, and it needs to be done. And then the last suggestion I would have in this area is that community providers need to be well aware of how to bill Medicaid. And the people that approve the payments need to be educated about infant mental health. This has to do with how you document what's happening, how medical necessity is documented, use of the proper billing codes. It's sort of the nitty-gritty of how to make this system work, but many states have looked at this as a way to really make this system very tight and efficient, and avoids duplication and wasted effort. All right, let's move on to the third area. And remember when I talked about the continuum, I said that this is not a separate system. These are services and supports that exist within other systems. And so integration is a big part of making this all work. So for advocates and policymakers and philanthropy, grant funders, infant mental health really should be considered when making budget and policy priorities. As I said before, there's a very high cost to trying to repair the effects of trauma and ACEs later in life. And here's where I'll highlight the work that Alaska did. They were interested in submitting a Medicaid waiver, which means they were going to ask the federal government to waive certain requirements in Medicaid so that they could address specific populations with specific services. And at the same time, they had done a lot of work looking at their adverse childhood experiences. They had a really, very high rate of trauma, drug abuse, alcoholism, isolation, depression. So they had high ACEs. They used surveillance data, epidemiological data, and found that about 40% of the state's adult Medicaid enrollment could be linked back to early adversity. And when they did this study in 2012, they estimated that they could have saved $350 million of Medicaid costs if they prevent or eliminate ACEs. And when I saw that number, I thought, what I could do with $350 million. So it's huge savings. And as far as I know, this is the only study of this kind. And I just checked to see what the status of that Medicaid waiver was. The way that they used this in their waiver application was to justify the inclusion of early childhood mental health services, including consultation. And although the federal government has approved a portion of the waiver, the rest of it is still being negotiated, but they do expect approval sometime soon. So I'll go back and look and watch the progress that they're making up there. So that's a big one, budget policy priorities. Many states have also formed interagency task forces. You've got to have a broad representation of just state agencies working on this effort. A third suggestion for action is to fund a statewide system of mental health consultants. And it's so nice to say, oh, Ohio has really made a lot of progress here. It's something that needs to be continued. Many states have looked at different models where mental health consultation is available to early intervention providers, to home visitors, but also to WIC, to domestic violence shelters. And I love it. It means that someone is at hand when the children and families are there and in need of the guidance. So there's still a lot of work to be done to figure out how to get that paid for in ways other than just straight state revenue, but it is a really good approach, a great model, and I'm so happy that Ohio's done the work that they have. Embedding infant mental health as a prevention strategy means looking outside of just mental health to do this. So, for example, Virginia is training all of its home visitor supervisors in reflective supervision. They found that it reduces burnout, it reduces turnover, which of course is cost savings for the agencies. In Oregon, the Medicaid agency considers abuse and neglect as a primary diagnosis so that infants and young children who are in child welfare can have access to behavioral health. In Los Angeles, they have created perinatal psychiatric consultation for pregnant women who, especially pregnant women who already have a pre-existing mental health condition. Maybe they've had chronic depression, now they're pregnant, and these perinatal consultants work with the obstetrical practices, with the labor and delivery nurses, with the postpartum care, to make sure that there's both continuity, but also that someone is thinking about the mom's mental health, the baby's mental health, and their relationship together. So, just thinking about how infant mental health could be embedded in other systems. All right, let's move to the fourth area. Cultivating leadership inside and outside state government. This is, it seems like a no-brainer to say someone needs to lead the charge, but it's not always real high up on the priority list. So many states said, what really helped us get to the tipping point was having someone at a high level who was in charge of moving forward a strategic mental health plan across agencies and across systems. So in Colorado, they have a director of early childhood mental health who's in the governor's office. In Virginia, they have a state position that actually 3 state agencies fund, and then the position is actually outside state government, uh, uh, physically located at Virginia Commonwealth University. So that's where the inside-outside state government comes in, where you've got a lead person and a strategic plan, but they are able to leverage supports from both inside and outside state governments. In Massachusetts, one of their tipping point activities was a summit, an infant mental health summit that their children's advocacy organization, their departments of public health and mental health and Medicaid all came together to pull it off. And the having of the event was almost less important than getting the commissioners of those state agencies and their children's advocacy director together at the same table, at the same time, all saying the words infant mental health. So they were, very proud of the way that they had leveraged that inside-outside government approach. Mapping the mental health and early childhood services and doing an annual assessment, that all has to do with planning, having a plan and carrying it out. Let's go to the next slide. And part of this leadership notion is also building champions and conducting public awareness campaigns. In New York, I believe it's still the First Lady of New York who launched this first 1,000 Days on Medicaid initiative. They have a 10-point agenda that includes infant mental health strategies. They also have a cross-sector work group that has 200 members. It's probably why they needed a 10-point agenda, so that they could break that group of 200 up into smaller groups. But they are looking really across the board at managed care. They're looking at a developmental inventory for kindergarten entry. They're looking at pilot testing a peer family navigator approach. They're looking at data systems. They're looking at home visiting, and they're looking at mental health. So that is a really huge effort. But as a result of that, they've been able to create new champions. Who did I want? I wanted to mention Massachusetts as I mentioned their summit, but they also launched a public awareness campaign about early social and emotional development that they launched in bus stops throughout the city of Boston. It was very successful. They were able to track referrals. They were able to track follow-up. As part of that effort, they had family navigators in pediatric practice and other child-serving agencies that helped families actually connect with the referral sources. So it was a very comprehensive effort. And then finally, encouraging public and private partnerships. In Colorado, they had several foundations that came together and added on to a federal grant. They called it Launch Together, where they selected additional counties to be part of this federally funded launch effort, so that they could really build on and leverage as much funding as they could, and keep things moving along all at the same time. So those are many, many, many ideas about things that could happen to advance infant mental health. If you want to go to the next slide, I'll just just summarize again. These 4 areas of activity: workforce development, integrating systems, securing financing, and cultivating leadership, I think are four key areas that if there were a strategic plan in Ohio and with leadership, we could really make things happen. So I'm going to stop talking. There are resources on the next slide if you want more information. And Lynn Ann, I think we can
Sure.
open up that. So I don't know if there are questions, but
I don't see any typed in questions yet, but if anyone has questions on the line, they can enter them into the Q&A. Because we have a number of people on the line, I think that'll be easier than, easier than speaking or unmuting you. So just go to the top of your webinar screen and choose Q&A if you have a question. And in the meantime, I'll ask one. Cindy, Groundwork Ohio and a number of stakeholders, both inside and outside state government, just actually spent the past few days talking about how to advance vision for young children through Medicaid managed care reprocurement. And really interested in this Alaska study. I wasn't aware about it before. Maybe that's something that you could share with us and we could share with others. We certainly would love to be able to replicate something like that in Ohio.
Yeah, I will definitely send you a link to that. So I know that the epidemiological information that they used was from their behavioral risk surveillance system, which is generally done through the public health department. They call it their BRFIS study. And so that was the unique piece about Alaska, because other states have done ACEs surveys to see what the prevalence of ACEs are. There are also those studies out there, but I think that the mechanism for the Alaska study and that the way that they used it were really unique and very powerful. Unfortunately, there are just very, very few return on investment studies in early childhood mental health. And part of the reason for that is that we don't, when services are billed, there are no specific codes, so we can't track back, what services are being provided for which diagnoses. So it's difficult to do in a system where there's nothing specific about the early childhood mental health portion of it. But I will definitely send that link, and we can even add it to this resource list.
Thank you. I do see another question. And the question is, how can advocates craft messaging around the notion that infant early childhood mental health can occur, or I guess concerns probably can occur despite parenting practices and family support?
Yeah, there's, so there are a number of campaigns that have successfully done that. And I'm thinking that what this question is all about is, how can we support families in all kinds of circumstances? And that's a very positive message. And when we did focus groups during some communications research that 0 to 3 was doing, and we literally traveled around the country and met with parents and child care providers and pediatricians to say, what message really resonates with you? It was messages about children getting along with other children and children being kind to other people, and families really wanting their children to do better or to have it better. The most compelling messages came directly from fathers in the focus groups who several of them said, I didn't have a father, or, my father was really rough with us, and I want to be a different kind of parent. And it was like, wow, those are really powerful. So I think those are part of the messages, but maybe another resource that I will add to this, 0 to 3's developed some messaging guides that has sample messages, sample public service announcements, sample sort of tagline kind of messaging that you can use. So there are definitely some good messages that have been developed, and maybe I can work with Lynn Ann to make some of those examples available to you. That's a great question, though. Thank you.
Thanks, Cindy. I don't see any more questions at this time. Feel free to type in here within the next couple of minutes as we wrap up, and we can go back to questions, but I don't see any more right this second. We have a couple more minutes left in the hour, and so I just will say thank you for joining us, and Cindy and I will work together to get those resources available to you. They will be on Groundwork Ohio's website, which is www.groundworkohio.org. You can navigate to our early childhood mental health webinars or go directly to www.groundwork.org, groundworkohio.org/ECMH webinars. Again, you can register there for our upcoming webinar on October 9th. And we thank you again for joining us today. Please feel free to reach out to us anytime as a resource, and we look forward to providing these additional documents and the recording of the webinar online next week. And I don't see any more questions that have come through, Cindy, so thank you again so much for joining us, and everyone else have a great rest of your afternoon.
Thank you.
Bye-bye.